EASL was a very interesting meeting. It was full of stimulating findings, and so I'll try to walk you through that in the time I've allocated. This is the list of things I want to report back on. It's the WHO Global Hepatitis Report, it's the new EASL HPV guidelines, some of the emerging data on patients who are switched from TDF to TAF, just touch upon the Hepatitis B Cure Agenda, talk about HPV reactivation under DA therapy, address the issues around HCC risk following DA therapy, look at DA therapy in children, hepatitis C therapy in real-life cohorts, new DAs, treatment after failure, and elimination studies. 1, 2, 3, go! So the WHO report, I think, was interesting because it really shows you the gap, particularly when you look at the numbers and the envisioned of getting sort of the numbers down of people being infected, increasing the number of the people diagnosed with viral hepatitis, and you can see that overall there are 257 million people living with hepatitis B, clearly making this the most prominent viral infection. And of note, and I think that's at least reassuring to see that in children under 5, the rate of chronic hepatitis B has been reduced from 4.7 to 1.3 by immunization, and clearly highlighting the role of vaccination programs. Clearly there is a disbalance in the regional distribution of hepatitis B, really making Africa and Western Pacific the prominent region of hepatitis B infection, and where there's still a lot of things which need to be done. The numbers with regard to hepatitis C show a quite dramatic decline. If you think of the published literature and reviews around the epidemiology of hepatitis C of 10 years ago, it always starts with like 140 to 180 million. That has been now down to 71 million, which I think is important because it means we need much less treatment, which also means much less cost, and I think that at least is something which should encourage countries who are a little bit more hesitant in delivering DA therapy to get started. You see this is a global issue, but again, there are also hot spots, in particular Eastern and the Mediterranean region. Hepatitis mortality through all viruses, however, is still increasing. There are 1.34 million deaths in 2015, and so this really underlines why viral hepatitis should be upfront. Clearly, the majority of deaths are related to HBV and HCV complications, in particular cirrhosis and liver cancer. New guidelines around the management of hepatitis B have been issued, and I think one of the important findings is the sort of attempt to simplify the classification of hepatitis B and really moving from all these who's immune tolerant and immune active and inactive care and so forth to more simple separation of chronic infection versus chronic hepatitis. So if you have normal liver enzymes and no liver disease, then it's more an infection, chronic infection, and those who have elevated liver enzymes and are prone to moderate or severe liver disease are then those with chronic hepatitis, and I think that may help in the setting of HB antigen as well as HB antigen negative patients. Following the registration of TAF as a new tenofovir formulation with a new prodrug of phenamide, allowing lower systemic tenofovir exposure, and as a consequence, less renal and bone toxicity. Data is now emerging from the hepatitis B field as well, looking at patients who were switched from TDF to TAF, and really you see continued suppression of HBV DNA, but more importantly, you see an improvement in bone density markers and improvement in GFR, and clearly for patients out there who are aging and increasingly have renal issues, it's of importance that we now have an alternative agent which may be used at much lower GFRs and doesn't hold the risk for bone and renal toxicity as tenofovir does, and that has been also reflected in the guidelines where the choice of entecavir or TAF in the presence of a patient with chronic hepatitis B is particularly emphasized in patients with bone disease or renal alterations. The conference was full of busy presentations around the HIV Cure Agenda, and this just highlights at all the various points within the hepatitis B replication cycle where studies are ongoing or have been presented. Clearly, this will be summarized earlier in the afternoon today by Patrick Kennedy, who will give I'm sure, a wonderful talk on the current HPV Cure Agenda. So I'll skip, and that leaves me also from going into the details of all these very complex studies. It's fantastic. Just look at the slide and go to Patrick's talk, and he'll tell you all about it. With regard to the hepatitis B reactivation, I think this is something of at least concern. There was a recent publication in the Annals of Internal Medicine following a first report at EASL last year from the FDA, which summarized the findings of 29 cases of hepatitis B reactivation in patients receiving DA therapy, most of them coming from Asia. And of note, some of those patients who were in this series of case reports had relatively bad outcomes. Some patients died, some required liver transplantation, quite a number had to stop their therapy, and some were hospitalized. So clearly there was a word of concern. The question though was who is really affected and which patients are we looking at? It really looks as if it's particularly aiming at patients who have chronic hepatitis B concomitantly with hepatitis C, so patients who have a chronic HBs antigen positivity clearly are patients which probably need a special monitoring. I think the overall recommendation, first of all, obviously should be that any patient receiving DA therapy should receive a hepatitis B screening prior to starting DA therapy, and then the question becomes how high is the risk of reactivation. And so this is the first larger kind of prospective trial in patients with chronic HBs antigen from Taiwan, which included quite a number of patients, 111 with genotype 1, 43 with genotype 2, all were also HBs antigen positive. And it did include also some cirrhotic patients, also included some patients who had low-level HBV DNA viremia. Remember that there are viral interactions when you have various viral infections. Usually one virus takes over, and quite commonly you will find low levels or no level of HBV viremia in patients who are dually infected. Now, interestingly, in this study, none of the patients experienced clinical signs or symptoms of HBV reactivation, so there was no one who got really very sick. That is a reassuring message that probably the likelihood of a severe complication is low, but there were at least 63% who had asymptomatic HBV DNA reactivation, so there is an increase in HBV DNA level, but that seems to be, in most patients, asymptomatic. Note that patients with higher liver enzyme elevations at baseline and higher levels of viremia, as you would expect, are more prone to develop a higher HBV reactivation, defined as a higher increase in HBV DNA levels. And that has encouraged guidelines to say that in patients who have HBs antigen, elevated liver enzymes, and detectable HBV DNA, you may preemptively want to give nucleoside or nucleotide. Patients who have no liver enzyme elevation, you may just do increased monitoring under therapy in the setting of a dual HBV-HCV infection and a patient is about to start DA therapy. With regard to the risk of hepatosolic carcinoma, this already goes back to a Spanish study from the Barcelona group looking at the risk of HCC recurrence. So patients already had a prior hepatosolic carcinoma and then were receiving DA treatment for their hepatitis C, and then they reported a somewhat higher rate of cancer in those patients, and that's sort of a whole range of investigations and studies. And really, EASL was full of studies addressing pretty much the same question, and some were targeted around the risk of HCC, particularly with regard to patients who had a prior occurrence of liver cancer. So in these Italian study looking at recurrence of liver cancer in HCV cirrhotic patients treated with DAs, it really was nice in the sense that it was able to dissect which patient has the highest risk, and that seems to be the patient who has a larger tumor size and a history of prior HCC recurrence. So obviously there are different risk groups, and that means that if you look at these analyses, you have to be very careful because it will depend on which kind of patients you include. And if you look at the Spanish data more critically, you will see that over 40% of the patients had their recurrence within like the first 40 days after stopping DA therapy, which suggests that maybe some of these patients just had unfavorable factors and were already at risk of developing cancer. And so this may overall be more a biased selection of the patients included into that particular study. There was then, for the patients with regard to HCC recurrence, a meta-analysis from Australia, and you can see they put together all the studies which have been addressing that so far, and that included those from the interferon treatment era as well as those from the DA treatment era, and you can see that there was really no difference between the two treatment paradigms. and overall treatment was beneficial, and there was no impact or no signal of a higher rate of HCC recurrence in this meta-analysis, reassuring us that there is no increased risk for our patients. There were then individual studies looking at the occurrence of HCC, so new onset of liver cancer in patients with hepatitis C-related liver disease treated with DAs, and this is a very large Sicilian study with almost 2,500 patients with cirrhosis undergoing DA therapy with a very regular check for liver cancer every 6 months ultrasound. There was a 14-month observation period after starting DA therapy. Overall, 78 new liver cancers were noted, which amounted to a 3.1% over that observation period of 14 months. And you can see that this was higher in the patients who did not achieve SVR versus those who did achieve SVR. And if you look at the unfavorable risk factors, was not achieving SVR, and it was a low albumin and a low platelet count, which are indicative of more advanced liver disease. And we all know that patients with more advanced cirrhosis stages are higher for the risk of developing HCC. So it doesn't really look to be a direct effect of DA therapy, but really more reflection of more advanced patients receiving therapy. This was then also entered into a meta-analysis looking at new onset of HCC following SVR, and that was again split between interferon-based regimens and DA-based regimens. And also in this meta-analysis, there was really no difference seen between the regimens used, and the treatment was also protective rather than leading to an increase of HCC occurrence. One of the final patient populations left to study obviously has been children. I think this does play an important role, as in countries with high endemicity for hepatitis C, there is a risk of perinatal transmission. Think of Egypt with an overall prevalence of hepatitis C around 8%. Think of some of the more recent outbreaks of hepatitis C among IV drug user populations, also in North America, with a relatively high perinatal HCV transmission risk. So there is some interest in how to deal with hepatitis C in younger patient populations. Obviously, that's always difficult to develop, but this is the first open-label study of half-dose ladipasvir sofosbuvir plus minus ribavirin, dose adapted in children aged between 6 and 11. And you can see that the overall response rates here were excellent, with pretty much 99% responding. Was only one relapse in the children. So also telling us that in these patients, if there is a need for treatment, there seems to be a strategy which can be brought forward. There was really a huge amount of real-life cohorts, and I think you have seen this morning already in Rui's very nice overview in the treatment of IV drug users, even those with use of cocaine and heroin, excellent response rates. And I think this is echoed in all the different real-life cohorts, that principally any kind of patient population you take mirrors what has been achieved in clinical trials, and excellent response rates, regardless of which kind of new or specific antiretroviral combination you're looking at. So the real-life cohorts really stress that the SVR rates are comparable to clinical trials with excellent safety reports, and I think it underlines that we really should use these agents in all patients' populations. There's always a focus on new drugs, although you may say, is there really a need for further development of antivirals at this point? Clearly, at least from a cost perspective, every additional fixed-dose combination allows increased competition. So at least from that perspective, this is already, I think, good news. And then obviously there's some little remaining niches where you sort of think that maybe tweaking a little higher SVR rates may be promising, including patients who are more challenging to treat, which still includes the sort of more advanced cirrhotic patients. And then obviously treatment-experienced genotype 3 still remains a somewhat more challenging patient group to tackle. Now, probably the new drug combinations which had the most, or the biggest wealth of data, was coming from the new AbbVie fixed-dose combination, which consists of glucapravir. This is a pangenotypic protease inhibitor, which is co-formulated with pibrentasvir, which is an NS5A inhibitor. So this is a PI with an NS5A inhibitor. It's a new fixed-dose combination. There's high barrier to resistance, great in vitro data, and is also not excreted renally, so also offers promise in the treatment of patients with renal insufficiency. They presented a whole series of studies, including somewhat more tricky patient populations to treat. And the first one was the Exhibition 1 study, which looked at the safety and efficacy of GP, and that's really the easiest way to formulate it, for 12 weeks in patients with all genotypes except 3 and compensated cirrhosis. So it's 12 weeks of the fixed-dose combination, 1 tablet. It's co-formulated, it's 3 tablets per day. Given once daily. You see that in this study, which included 146 patients, 62% were male. You see the genotype distribution, so although all genotypes were allowed except 3, you can see that the majority, following the natural distribution of genotypes in this predominantly North American study, is genotype 1A and 1B, but there was a fair amount of genotype 2 and 4 as well. Looking at the disease characteristics, you can see that this included naive patients, mainly 75%. There were also patients who had received interferon-based regimens or soft-based therapy before. And the patients were cirrhotic, but I think it's fair enough to say that the amount of patients with a low platelet count below 100,000, only 20%, so clearly this is not the far end of liver disease, if you think about it that way. But looking at the overall response rates, I think we would all agree that 99% in a cirrhotic patient population is fantastic, and clearly this offers quite some promise, also under consideration of its pangenotypic activity. And then, again, I think what we all have seen under the DAA therapies is clearly the extreme well tolerability, no discontinuation because of adverse events, I think really highlighting the superb tolerability of these regimens. Expedition 2 was a study looking at 8 or 12 weeks of GP in HIV, HCV co-infected individuals with or without compensated cirrhosis. So those patients who were non-cirrhotic received 8 weeks. So clearly this regimen is also aiming at a shorter treatment duration, at least for the easier to treat non-cirrhotic patient population. And then it was 12 weeks for those individuals who had cirrhosis. But you can see that that was a very small number of patients who were included. Again, the overall efficacy results were good. There was only 1 patient relapse, and that was a patient from our own center. It was a genotype 3 patient with very advanced cirrhosis who had on-treatment failure. There was also an adherence issue, but otherwise all patients were cured in that study. And then the Endurance 3 study, which looked at the GP combination, started off as a comparison trial between 12 weeks of therapy for genotype 3 patients versus the sort of previous standard of care, soft and declatosphere, for 12 weeks. And then because of the good results from previous studies, they also included then an arm of 8 weeks of GP. Looking at the baseline characteristics, you can see that they were well balanced. Half of the patients were male. You can see that over half of the patients also had a history of injection drug use, so I think also true reflection of what we see in clinic. Only patients who were non-cirrhotic were allowed to be entered, and you can see that the amount of patients with genotype 3 and F3 fibrosis were relatively few, a little higher in the 8-week arm of the trial. Looking at the overall results, you can see that the response rates were excellent, and there was really no difference between the 3 different regimens. So GP was comparable to soft declatosphere, and that was true for the 12 as well as for the 8-week arm. Looking at the treatment outcomes, you can see that although overall there was no significant difference between SVR rates, there were 3 relapses in the 8-week arm versus only 1 in the soft DAC and the 12 weeks of GP. Again, tolerability was excellent for the 3 regimens studied. Looking at the resistance, of note, patients who only had NS3 polymorphisms at baseline seemed to respond very well. If you only had NS5A, also good responses throughout all arms, but if you had NS3 plus NS5A polymorphisms, that seemed to have a little hint on the overall response rate. And that brings us right into the next study, which is the Megalon-1 study, looking at the GP regimen in patients who have received prior DAA therapy. And I think that is one of the remaining issues. So if you have a busy clinic, and I would presume, as we saw the Portuguese data today, if you treat your 300 patients and you have SVR rates of 95, 96, 97%, there's still these 3% which remain a challenge, have obviously then failed a first regimen, most likely harbor polymorphisms after failure. And the question really becomes, what is the best strategy? Do we wait for new regimens? Can we use other regimens? What to do? And so this data, I think, is eagerly awaited in the clinic to sort of make better pragmatic decisions on what kind of treatment approach we have for patients with prior DA failure. And of note, if you're basing all your hopes on the GP regimen, I think there is at least one challenge. So clearly, if you have PI mutations only, that seems to have no impact on the overall efficacy of the regimen. If you have NS5A only, and what I didn't say is that they also looked at 12 weeks versus 16 weeks, I should say that. So 16 weeks at least looked a little bit better for the NS5A only, but if you look at the PI and NS5A combination group, that seems to be the group where the overall cure rates somewhat go down, and you already saw a hint of that in the previous study where I showed you that the relapses were higher in that particular patient group. So clearly, I think if you have mutations in both groups, that would probably not be your preferred choice for salvage therapy in previously DAA-treated patients. And that's important because it says two things. The first is that probably resistance testing after DA failure makes sense, because only if you know which mutations you have and which corresponding drug class, you will be able to make your best selection. So the question then becomes, well, if that is maybe not the ideal regimen, at least in the presence of PI and NS5A mutations, could this all be rescued by the occurrence and introduction of so-called triplets, so regimens which include drugs from 3 different drug classes. And of note, what I didn't say before is that the GP combination, as well as this combination we're going to talk about in a minute, the Sofel-Vox combinations, are both combinations which are already undergoing the registrational process. And it's expected that in the summer, at least, they will become available in North America. So really, our armamentarium will be growing very shortly. This combination is holding 2 components which we're already quite familiar with. This sofosbuvir, obviously around for quite a while, and then the NS5A inhibitor valpatisvir, which you know in the commercially available Epclusa formulation. And now there is an addition of a protease inhibitor, voxilatravir, which we will abbreviate as VOX. So the Sofel-Vox combination is also pan-genotypically active, can be used for all 6 genotypes. And if you look at the integrated efficacy analysis of Polaris 1 and 4, which are both studies in previous DA failures, you can see that in these results from EASL, overall excellent response rates on average, over 95% were achieved. So clearly highlighting that we have a very, very, very good overall efficacy, and this may be a good way forward for patients with previous DAA failure and resistance development. And there was a nice resistance sub-analysis by Christoph Sarrazin looking at the patients from Polaris 1. These were DA-experienced patients who had previously received an NS5A inhibitor, so mostly adipasvir. And you can see that the majority of patients did have NS5A mutations, half of them alone, 29% in combination with NS3 polymorphisms, and you see that the impact on SVR rates was not present, so it doesn't seem to bother in the presence of a 3-drug regimen. And then if you look at the Polaris 4, which had the inclusion of DA-experienced patients who had not received an NS5A inhibitor, you also see very good results independent of the baseline polymorphisms, suggesting that this regimen is relatively strong and robust even in the presence of baseline mutations. The next study presented is a new combination of grozepivir, which you may already know in the Merck combination, fixed-dose combination of grozepivir-albasvir. This is now taken together with a new NS5A inhibitor, ruzasvir, and that is then combined with an NS5B inhibitor, rupifosbuvir. So this is a new 3-drug regimen, which is formulated as a fixed-dose tablet, but has to be administered as 2 tablets once daily. If you look at this particular study, this is again a study which looked at patients who relapsed after regimen of ladipasvir, sofosbuvir, or albasvir, grozepivir, so 2 regimens containing NS5A and 1 also on top with a protease inhibitor. And they randomized patients to either 16 weeks of the triplet combination or 24 weeks of the 3-drug combination. You see the baseline characteristics here. You can see that the majority of patients had failed ladipasvir, sofosbuvir, around 60% failed 12 to 24 weeks, and then there was a smaller group of 8 weeks failure of ladipasvir, sofosbuvir, and then there was around 20 to 27% who failed 12 weeks of albasvir, grozepivir. If you look at the overall cure rates, you can see that in the 16 weeks plus ribavirin, all patients responded in the modified. There was no relapse, and there was also no relapse in the extended duration of 24 weeks with no ribavirin. So clearly, this at least is very promising because it sort of indicates that every patient could be cured in that particular combination, and clearly, overall, it looks as if 24 weeks without ribavirin would be a great way forward if you want to get rid of the ribavirin altogether. And clearly, we'll hear more about regimens with these new compounds. Adverse events were good. They were somewhat higher in the ribavirin-containing arm. There was more pruritus, more rash, as you would expect. Otherwise, again, good tolerability and no discontinuations related to adverse events. And the last kind of thing I want to highlight was a symposium, and I'm glad I chose it because I know we have a lot of Georgian delegates here as well, which sort of reported back from the hepatitis C elimination program in Georgia. You know that Georgia has in the very special situation of having a free access to DAs, which are donated by Gilead, but on top they have a very active and committed political environment which has brought forward a very intensive program which does not only include the treatment of patients but also is sort of an effort to increase screening and working on all different fronts to make the WHO ambitious goals happen even earlier in Georgia, and we'll see whether that is true or not. You see that here, with the current treatment rate of around 25,000 per year, there will be a 87% reduction in prevalence by the end of 2020. So I think the big challenge here is now to identify all patients who have hepatitis C. I think that is the holy grail in the Georgian hepatitis C elimination program, because there's still a lot of patients which have to be found. They have shown that they are capable of treating 30,000 or 25,000 per year, and they have shown that the SVR rates are very superimposable to what has been achieved in clinical trials. I think it's now the big challenge of finding the remaining patients to make these ambitious goals happen. But I think what is important is that elimination is something which is happening in model countries, and I think that should all be an encouragement for other countries to make that happen too, because a lot of it is sort of a combined effort of all stakeholders in the HCV arena to make that all happen. So let me summarize. There are new EASL HPV guidelines, and you should download them from the EASL website. Clearly, TAF is the first new treatment option, which I think is eagerly awaited, at least in patients with renal insufficiency and prior 3TC HPV resistance, because that allows a new treatment option with much less bone and renal toxicity. I think the WHO report was a little bit sort of eye-opening in the sense of that they're really highlighting that in order to achieve the wonderful goals by 2030, we really have to increase our efforts quite tremendously. Only 20% of all hepatitis C infections globally are estimated to be diagnosed. So clearly, if we want to increase that to 90%, there's really a huge way to go. Hepatitis C treatment coverage is still below 10%, so clearly even further away. And again, I think we really have to reunite our efforts to make this all happen. There are an onset of new pangenotypic regimens, which I think are useful additions, particularly for genotype 3, for cirrhotics. There is the option of shorter treatment durations and not so difficult to treat patients. And I think the onset of triplet regimens will allow salvage therapies for those few patients who have failed prior DA therapy. Thank you very much.